Hi, I'm Vicki Miller. I'm the Patient Education Manager with the CLL Society, and we're here today with Dr. Brian Koffman to talk to you about CAR T therapy. Dr. Koffman, would you please introduce yourself?
Hi, I'm Dr. Brian Koffman. I'm the Chief Medical Officer, Executive Vice President of the CLL Society, and I'm a CLL patient and a CAR T patient myself. Thanks for inviting me, Vicki.
Sure. And so we're going to talk about CAR T therapy. Can you tell me or tell us why CAR T is a therapy to consider?
So, for CLL patients, we have several excellent therapies, but generally they fall into two broad classes: BTK inhibitors like ibrutinib, acalabrutinib, zanubrutinib, and recently pirtobrutinib, and BCL2 blockers like venetoclax, the only one, though others are in development. When patients have become intolerant to those, or those are no longer working for them, they have to look for other options. And those options are quite limited. And one of the best possible options for them today is a clinical trial of CAR T therapy.
Okay, can you explain exactly what is CAR T therapy and what that procedure is like?
So those are two big questions, and they're different questions. So CAR T therapy is a cellular immune therapy. So let's start with the fact that it's cellular. So most therapies that we think of are done by liquids, by chemicals, by large molecules, but not by the cells themselves. Here, the actual drug is the cells. And the way, and this is getting into what CAR T actually is these cells are your body's T cells. T cells are a type of lymphocyte. There are three kinds of lymphocytes: the B lymphocytes, which make antibodies, and that's where the CLL cancer occurs; the T cells, which are the soldiers of the immune system and also the generals ordering the soldiers, and that's where the cells themselves do the dirty work of the immune system in the natural killer cells. What happens with CAR T is these T cells are taken out of the patient who has CLL, and it's essentially a fancy centrifuge. There's an IV in one arm that takes the blood out, and an IV in the other arm that puts the blood back in. But before it goes back in, it's spun, and the T cells are spun out. And then while these T cells are ex vivo outside of the body, they're infected with a retrovirus that inserts genetic material to teach it to recognize and attack the B cells, the cancerous and non-cancerous B cells, generally CD19, but there can be other targets, CD20, and there can be other targets that are found specifically on CLL cells like ROR1. And this is also used with other targets for other kinds of lymphoma and multiple myeloma, but I'm just going to talk about CLL now. These cells are then carefully expanded outside of the body, and then they're reinfused into the patient, these newly educated cells, which are like targeted assassins. And then these assassins go back into the body, sleep for a while, and then they wake up, massively expand, and go on a killing spree of killing off the B cells. And hopefully they knock down the B cells to such a low level or completely wipe them out. The patient has a very long, durable remission, and there are even cases that look like cures now. So it's a combination of an immune therapy and a cellular therapy, but it comes with certain risks. Obviously, this whole procedure is a bespoke procedure. It's individual for each person, so it tends to take some time, and it tends to be an expensive procedure. Also, there are side effects, collateral damage of all this killing that goes on. And among the things that are involved with this is, in order to allow the body to accept these T cells, we have to kind of soften up the patient's immune system. So there's a little bit of chemo that's given before, so they don't reject these cells, even though they're their own cells. They've been changed. Second, when these cells expand and do their killing, there's an inflammatory reaction, and the inflammatory molecules are called cytokines, and these can be massively released. This is called cytokine release syndrome, which you may have heard of in relationship to COVID. Well, here this cytokine release, or CRS, can happen, and it can be always annoying and sometimes quite serious for patients. Fortunately, we have tremendous medications that can help with it. So the best idea is just to be prepared for it, accept that you're going to get this CRS, but know that it can be well managed. There's another toxicity, a neurotoxicity, which is immune modulated, and it's seen also with CAR T therapy. And again, it's an inflammatory reaction, and people can get quite sick with this. They can stop talking. They can have stroke-like symptoms. They can go into comas. They can have seizures. But almost always, there's a full recovery from the neurotoxicity and the cytokine release syndrome. The other thing is, if the therapy works, you don't have any B cells. And if you don't have any B cells, you don't make antibodies. And if you don't make antibodies, then vaccines don't work for you, and you're at higher risk for infections. So people who've had successful CAR T therapy have to be on immune globulin replacement therapy, stuff like intravenous immune globulin, or IVIG, for the full time, or for at least years after getting CAR T therapy. And there's other adverse events associated with it. But it's a remarkably successful therapy, and it's one of the things that I really like about it. It's one and done. You go through this, admittedly, a difficult period of a few weeks, but with those few weeks, if everything goes well and you get a complete remission, then you can have a very durable response. I'll share the details in my case. I had a unpleasant cytokine release syndrome, but nothing life-threatening, but nothing I would wish on anybody else. It was very painful. It was difficult, but I got through it. I had to be on lots of drugs to get through it. But at the end of the month, when I was restaged and my CLL was very active and had become resistant to ibrutinib, I was in a complete remission, essentially. I had one node that was 1.6 centimeters, and nodes have to be 1.5 to be full remission. So I was technically in a partial remission, but in reality, it was like a complete remission. And when they looked down to 1 in a million cells in my bone marrow, they could find no evidence of the CLL. And that kept me in remission for over 5 years. So it was one shot, 1 month of living in Seattle to have this procedure done, some scary, really, really unpleasant times, some complications, but 1 month, and then 60 plus months of a glide with really no therapy afterwards.
That sounds like a lot to go through, but potentially for you anyway, it was worthwhile.
Oh yeah, it was really the right decision for me. And there's no guarantee not everybody gets a complete remission. In fact, the majority of patients don't get that kind of deep response. But if you're one who does get a deep response and gets a complete remission, those tend to be quite durable. And for patients like myself and many others, now that we're living longer with CLL, when we run out of these therapies, these what I talked about, the BTK and the BCL2 therapies, CAR T is a really worthwhile option because it works entirely differently. The other therapies are targeted. This is an immunotherapy, and they just keep getting better and better. They're better understanding CAR Ts. They're better understanding what dancing partners are for CAR Ts. One of the problems in CLL with CAR T is our T cells are not the best. The CLL itself can have adverse effects on the CAR Ts, and they have this quote exhausted profile, so they don't work well. But drugs like the BTK inhibitors, like ibrutinib, which I took during my CAR T therapy, can actually tweak the T cells and make them more effective. And they're looking at other options and other medications to add that may actually help outcomes with CAR T therapy. So I'm very excited about the future of CAR T in CLL.
And I would just kind of reiterate that as a nurse for CLL Society, I found it very interesting and very fascinating, and I'm excited to see where it goes. Do you have any final thoughts about that you want to share with everybody about CAR T or any advice?
I think CAR T should be a consideration for patients who are looking at therapy options in CLL. I think right now it's likely to be a consideration for people who are running out of standard options because we have so many great options that are bluntly much better tolerated. But I think down the line, we may find that it's better to move CAR T up to earlier therapies when maybe the T cells are less exhausted and the patients may get even better responses by using this kind of therapy early. I heard Carl June say um, CAR T is a 20-year in the making overnight sensation. You know, CAR Ts have been decades and decades in development. There's a lot of excitement, but we're still very early in the story, and I think they'll continue to get better and better. I'm very excited about the future of CAR T therapy for CLL patients.
That's great. Thank you for joining us and sharing your story, sharing your knowledge and expertise on this topic. It's a really important topic, and as CLL Society will continue to bring the latest updates and news as the CAR T therapy develops.
Well, thank you for the opportunity to share my story. Thanks.